Hello guys, how are you? I hope that you are having a good day. It's a beautiful day out there. It's sunny, it's shiny, and seems that the weather is much better than the last couple of weeks. So I hope that you give yourselves the opportunity to go and do something fun to enjoy the day. Maybe taking a walk in a forest trail, or maybe going to biking or running or something interesting, whatever you like to do with this beautiful weather. All right. It's a pleasure to be here again with you. I'm going to record what it was left from our first class. As you have seen, psychopathology is a very extensive content, and it's unfortunate that we have just 8 weeks to cover such an important topic and such an important discipline. As I mentioned in our first class, this is like the foundations of your practice, because if you have a good understanding of psychopathology, then you're going to have a good understanding of your clients and what to do with your clients. So just keep that in mind, guys, because you need to try to take the most of these classes. Go and buy the books that I suggest to you. And of course, if you see any other courses out there that can help you to improve more your knowledge on psychopathology, go and do it, okay? Because it is beautiful, it's interesting, it's extensive, but it's also very important for your practice. All right, so let me share with you my screen and we can start talking about the topic that was not covered on Tuesday: psychopathology, classification, and assessment. So these are the three topics that we're going to see: classification in psychopathology, methods of assessment, and case formulation. Okay, well, the case formulation, we are not going to see them because you are already seeing that in the CBT class, and then you're going to have a whole class on case formulation. So I'm just going to skip that, okay? I don't want to confuse you. All right, so here, I'm sorry, I'm just removing some things. Classifying in psychopathology. So the first thing that we want to have in mind, guys, is, are we dealing with disorders, syndromes, or disease? People have a tendency to use them as a synonymous, and they are not synonymous necessarily. And it is important for you to understand what is the difference of these three concepts. With that in mind, I include this link to you, and I strongly suggest you go and read the whole link. Here I'm just going to open it so I can share it to you, and you can see what is this link about, and that you can go and do your reading, okay? So it's an article. It's an article on, there's a way to download it here, PDF download, okay? I'm gonna download it, and here you have the article. And it's an article where this doctor, Henry Nasrallah, I don't know how to pronounce his last name, it's talking about the difference between disease, disorders, and syndrome, and how the DSM-5 understand this, and in general, the mental health community understand this, and why it's important to know this. I'm just gonna focus on here, on the definitions of the three different things, okay? I'm gonna try to make this bigger for you. You will see. What is a disease? Well, a disease is a particular distinctive process in the body with a specific cause and characteristic symptoms. This is very important, guys. We know, for example, the disease of the COVID. Well, we know that there's a cause, there's a virus that it's affecting our immune system, and then we develop the disease, right? We can know the cause of it. Someone has cancer, okay? We know the cause of cancer as well. That is the cells not working appropriately, reproducing in an unhealthy way. and developing tumors, right? So we know the cause of the disease. That is very important, okay? There's a cause and then there are symptoms. Now, what is a disorder? Well, disorder is an irregularity, disturbance, or interruption of normal functions. You see, it's important to have that in mind, because in disorder, we are not talking about causes. We are talking, not even talking about specific symptoms. We are talking about irregularities, disturbances, or interruptions of normal functions. So something that was functioning appropriately now is not functioning appropriately. And the way that that can be manifest can be in different ways. And we are not sure of why is that happening. We don't have a specific cause that is causing that, that can help us to conclude why that interruption of the normal function is happening, okay? Now, what is a syndrome? Well, a syndrome is a number of symptoms occurring together and characterizing a specific disease. Now, here, as you can see, they are talking about this number of symptoms happening at the same time and that they are characteristics of something. For example, my son, he has the syndrome that I have shared with you, right? That is Cloves syndrome. Why is that we are not calling them disease? Well, because this is something that it's happening at the same time. Some syndromes, we don't know what is the cause of that, what is causing that. And on the other hand, in most syndromes, it's going to be lifelong. Okay, so my son was born with a syndrome and he's going to die with a syndrome. So you can see the difference now. Disease, we know the cause, that it's provoking symptoms. Disorder, something is affecting or having an impact in the regular function of something. And then syndrome is this number of symptoms occurring together and characterizing a specific disease. So we can have syndromes in the disease, we can have disorders in the disease, and we can have the disease just by themselves. But we can also have disorders without talking about disease, okay? Why? Because in the mental health field, for example, we don't know why people develop the disorders that they have. We have some ideas, we have some hypotheses, some theories, but we don't have clear way to conclude that this or that is the specific cause causing them. Actually, we will see that we want to take an approach where many variables are considered at the same time in the development of the mental disorders. There are genetical elements, biological elements, there are psychological elements, there are social elements as well. And the interaction of all these variables is what we think that it's causing the disorders, but not just one single variable, as the case of a virus, right? Or a bacteria. Now, when you read this, you will see also that this doctor is suggesting something interesting. He's suggesting that the DSM-5 should change the way that it's understanding mental disorders, the classification of mental disorders, and that we should have 4 major syndromes, okay? And those major syndromes will include disorders inside of it. We're going to talk that there's a lot of conversation nowadays around this, but they say 4 major syndromes: mood syndrome, anxiety syndromes, and psychosis and addiction syndromes. And he's saying this because many of the disorders that we have, they share similar characteristics. And it doesn't make sense in reality, or the other way to see it is that the DSM is actually just a sum of descriptions of behaviors and mood states that people have when they have mental disorders. But the DSM is not really telling us anything about the origin of these disorders. It's not really telling us why people are getting these disorders, okay? So he's saying, like, because we don't know these causes, it would be better that we just have these four main syndromes, and then we can accommodate people inside of these four major syndromes. Now, this is just one position, but again, the important thing for you guys is to have in mind, we are talking about disorders, okay? We're not talking about disease, because we don't know the cause of these disorders. All right, so I want to be mindful with the time, because neither you or myself want to spend a lot of time during the weekend talking about this. So we have two systems of classifications in mental disorders. The first one is the DSM-5, and the second one is the ICD-11. What's the difference? Well, the ICD-11, it's the system that used the World Health Organization to codify all diseases, all disorders. You see, that's why it's called International Statistical Classification of Diseases and Related Health Problems. Because we already said that we are not talking about diseases in psychopathology, but disorders, remember? So that's why the ICD has this distinction, diseases and related health problems, because they not only include diseases, but also disorders and even other situations that can impact health, okay? This is the World Health Organization system of classification. And it's important for you to know that this exists, especially if you later on want to work in research. It might be important for you to get familiarized with this system of classification, because sometimes in papers we use this, or when we are working with government organizations, I mean, in the international level, we want to use this one because it's like the common ground in the international community, right? Now, at the government level, I would say. Now, why then is that we are using the DSM-5? Well, because the DSM-5 is the system of classification of the American Psychiatric Association. And as you know, both the American Psychological Association and the American Psychiatric Association are very powerful associations, honestly. They have a lot of power. The psychological one is the biggest association in the whole world. So that says something about it, right? And they developed their own system of classification. They have been doing this for many years now. I think that it's since the 60s. And the DSM-5 is the latest version of their system of classification. And it has been since 2013, I think, that has been available, 2013. And this is the system that most psychologists and psychiatrists and counselors are using to communicate with each other. Not as much the ICD, because that's like more government oriented for public policies, I would say. But this one is like the more clinical oriented. It's the one that we use in daily basis for diagnosing our clients, to identify, to communicate with our colleagues, and also to share the information with the insurances. And if you ever been asked by a judge to attend court and give your professional opinion about a specific situation with a client or so, you might want to be aware that if it's here in the United States, it's more likely that they're gonna also ask about DSM-5 information. It might be that some judges can say, like, I want the ICD-11, okay? But generally speaking, guys, if you get very familiarized with the DSM-5, you're gonna do good, you're gonna be able to communicate with all your colleagues, and you're gonna be able to share the information with your insurance. Some softwares, when you are typing the information for the insurance, some softwares, once that you type the DSM-5 diagnosis, they're gonna convert that automatically to the ICD. That's very useful. And then you're gonna have both diagnoses, the diagnosis of the DSM-5 and the ICD. They don't have the same names, okay? They talk about the same issues, but they don't have the same names, and they don't have necessarily the same symptoms. So I know it's confusing, but don't worry. We're gonna study the DSM-5, and that's the one that you're gonna use the most. And the DSM-5, it's developed in the following chapters: neurodevelopmental disorders, schizophrenia, spectrum, other psychotic disorders, bipolar and related disorders, depressive disorder, anxiety disorder, OCD and related disorders, trauma and stressor related disorders, dissociative disorders, somatic symptoms, feeding and eating disorders, elimination disorders, sleep-wake disorders, sexual dysfunction, gender dysphoria, disruptive impulse control and conduct disorders, substance use and addictive disorder, neurocognitive disorders, personality disorders, paraphilic disorders, and other disorders. What are these other disorders? Well, sometimes your client, you know that something is wrong with your client, but you cannot find any of these disorders that match their symptoms or their behaviors or their characteristics. Then you can go to other disorders. Also, in other disorders, you will see that there are some disorders that are currently under research, and they have them there just to let you know that they are working on them, and maybe we will see them in the DSM-6 or the DSM-5 revised version, okay? Now, the DSM-5 has changed many things in comparison with the DSM-4 revised version. One of the main changes is that anxiety disorders used to be a classification where OCD and PTSD, they belong there. But now they remove them. Now they have like these two different classifications. One is for anxiety disorders, another one for OCD, and another one for PTSD and related disorders. It has been a lot of debate about if that was appropriate or not, but that is what it is right now. Then another thing that I want to share with you is the personality disorders. The DSM-5 has two different classifications. One that is just like the traditional way to understand personality disorder. This means just a list of symptoms or characteristics that you need to see in your clients. And then there's a new way to diagnose personality disorder that it's a more complex way, where you need to have in mind different symptomatology and different characteristics of the client and so on. That one is still in a process, in a research process. The DSM is presenting and they are telling us you are welcome to use them if you want. But I don't know if that's going to continue or not in the following DSM. So we're going to go with the classical personality disorder classification as well, okay? All right. Now, the DSM-5, it has many problems. Many people love the DSM-5. Many people hate the DSM-5. I personally am in between. I like because it allows us to have a common language. It offers us the opportunity to engage in conversation with other professionals and to understand better what are we saying and what are we trying to do with our clients. It is also a good tool for us to understand our clients better and therefore to provide a treatment for our clients. But the criticism that the DSM-5 is receiving is significant. Let's see some of them. First, does not classify psychopathology according to its causes. So we don't know what is causing these disorders. What we are having is honestly just a checklist of things that the DSM is telling you, go and take a look if your client has this or not. But because we don't have a cause, that we don't know really what are the causes of this, it is very subjective. And it is it is relying in the clinical judgment of the person. And honestly, the clinical judgment from one counselor to other counselor can be very different, okay? Especially if that counselor hasn't hasn't done their homework in studying psychopathology appropriately, okay? Then labeling can be stigmatizing and harmful. So there are people, for example, that they feel very good knowing that they have a disorder because now they realize, oh, I'm not crazy. This is something that many other people have. Like, for example, people with anxiety disorders, generally speaking, once that you say to them, oh no, what you have is a very common situation. It is called generalized anxiety disorder or social anxiety disorder or whatever it is. They're going to feel a relief. But in other cases, it might be harmful. For example, when you are talking about personality disorders, saying to the person that he or she has a disorder in their personality, that basically the sense of who they are is wrong, it can be harmful, right? And it can be used in ways that it's not appropriate. I have seen clients that they use the diagnosis of their partner when they are fighting to try to harm them. For example, yeah, right, you are saying that because you are a narcissist. So that's not helping. Or yeah, you are saying that because you have histrionic personality disorder. You need to grow up, right? Well, it's not useful. So, and there are many other ways. We already talked how in different political systems they have used mental disorders with their political to try to feed them in their political ideology and to try to force people to think in the way that they think. For example, in the Soviet Union, I already said to you that you were not allowed to be depressed. In the Nazi, we also saw that. And we even continue seeing that in different ways in everywhere, right? So it can be also stigmatizing and harmful. Number three, define disorders as discrete entities and not as dimensional entities. What does this mean? Well, what it means is that it is not as clear that we are talking about separate disorders. Many of these disorders, they share symptoms. It's very common to see clients that they are depressed and that they are anxious at the same time. And it is not as clear that they have two different disorders at the same time or that it is in reality only one single disorder. Same thing happens with personality disorders. It is not clear that it is as a clear cut as they are presenting that you either have this personality disorder or you either have this other personality disorder. And it doesn't make sense, the idea of having many personality disorders, because then we will be talking about having many personalities, although there's a disorder that used to be called multiple personality disorder, right? But in reality, we see that some people with personality disorders, they share symptoms from different personality disorders as well. And then finally, collection of hundreds of categories of disorders. And this is a very important criticism for the DSM. It seems that now anyone can have a mental disorder because they have so many mental disorders in the book, in the manual, that anyone could have it. Now they have even included grief as one diagnostic criteria for the major depressive disorder. And they are saying that if you are grieving a loved one, now it could be included as part of your major depressive disorder, which on one hand makes sense, but on the other hand doesn't make sense because yes, people with grief, they can develop major depressive disorder, but not all people who are grieving are going to develop major depressive disorder, even if the grieving takes a lot of time, right? Maybe I'm grieving my wife for 2, 3, 4, 6 months, or maybe even more. But who says that that is really a disorder and not an existential experience of losing someone that was so meaningful for me, and that after that adaptation becomes difficult and challenging. but not necessarily disorder, right? So we need to be cautious with the DSM-5. Now, there are some important concepts on the classification that we want to have in mind. Comorbidity, it talks about the co-occurrence of two or more distinct psychological disorders. So for example, it is very common to see comorbidity between borderline personality disorder and substance disorders, right? So when you have a client that he or she has more than one, that's comorbidity, okay? Hybrid disorder, disorders that contain elements of a number of different disorders. For example, anxiety depressive disorder. But again, remember guys, there's a lot of debate saying like, well, maybe it's not that they are hybrid disorders, but in reality is that they don't exist as that distinct disorders, right? But they are just part of a spectrum or a syndrome or something like that. And that's the third concept, disorder spectrum. The frequency of comorbidity suggests that most disorders in the DSM may indeed not be independent disorders, but may represent a higher order categorical class of symptoms. And I want to show you, it is not here. Let me see if, I don't know if it's gonna be a good idea to show you from the book. But it is unfortunate that you don't have the book, guys, because as I said to you before, it's a really good book. And you can see maybe here, this image, what they are doing. I'm gonna tell you what they are doing. They are saying that we could divide all the disorders in three spectrums. Spectrum number one, bipolar disorders, where you will include bipolar disorder 1, bipolar disorder 2, cyclothymia. Number two, it's distress disorders. There you're going to include major depressive disorder, generalized anxiety disorder, PTSD. And number three, fear disorders. There you're going to include many of the anxiety disorders such as panic disorder, agoraphobia, social phobia, and so on. So what they are telling us is it would be better to have this type of spectrums, because in that way, all these disorders that have so many symptoms in common will belong to those categories, and then it will make more sense. Now, I'm not so sure about these guys. It's a conversation going on. As I said to you in the first class, there's no consensus in psychopathology. There are people saying that disorder doesn't exist. There are people saying that they do exist. There are people saying that the DSM-5 is a terrible thing. People saying that it's an amazing thing. There are people saying that there's too many disorders. People saying that there are too little disorders. And there's neither consensus on how to treat these disorders and so on. So it's an ongoing conversation, okay? All right, now, some of the criticisms, they come even from inside the DSM-5. I want to present this video to you so we can talk about it after. It's an important guy from the American Psychiatric Association providing his criticism to the DSM-5. And let's see what you think about it, okay? I'm gonna minimize this.
Dr. Alan Francis is an American psychiatrist best known for chairing the task force that produced the fourth revision of the American Psychiatric Association's Diagnostic and Statistical Manual, DSM-4. He is now in the spotlight for his critique of DSM-5. His new book, Saving Normal, is described as an insider's revolt against out-of-control psychiatric diagnosis, DSM-5, Big Pharma, and the medicalization of ordinary life.
I think that our mental health system is in a mess now. And I'm afraid that with DSM-5, it will get even worse. People who are essentially normal are being diagnosed with mental disorders they don't have and being treated with potentially harmful medication they don't need. Small changes in the diagnostic system can result in tens of millions of people were normal the day before, suddenly qualifying for diagnosis. And DSM-5 has made many of these changes, I think, quite recklessly, without careful and independent scientific review, and without a concern about the possible risks involved, focusing only on benefits. I myself would qualify for a number of the DSM-5 disorders. When my wife died 5 years ago, I felt sad. I lost interest. I couldn't sleep as well. My appetite was more than usual, and I felt less energy. It was hard to work. In DSM-5, those symptoms, typical symptoms of everyday breathing, would be called major depressive disorder after just 2 weeks. And that wasn't major, it wasn't depressive, it wasn't a disorder. When you love someone and you lose them, that's just grief and sadness. Another very important change in DSM-5 is the huge expansion of a category called somatic symptom disorder. If you have a medical illness and you're worried about it, that becomes a mental disorder. This would qualify 1/4 of cancer, heart disease, and diabetes patients for a mental disorder because they're worried about their illness. Normality is impossible to define. It's a cultural concept rather than a medical one. And originally, there were only 6 diagnoses, and now there are about 200. Our society is already immersed in pill popping. 1 out of every 5 adults takes medication every day. 6% of the population is addicted to psychotropic medications. The sales of antipsychotics are $18 billion a year, amongst the highest of all classes of drugs. The sales of antidepressants, $12 billion a year. Stimulants, $7 billion a year. I think that from the point of view of clinicians, it's important to be cautious in your diagnosis. Don't jump to conclusions. Don't make fancy diagnoses after brief initial contact with patients. If you're a patient or a family member, what should you do? Don't stop your medicine. Don't go alone, because you may be in the category of people who really need it. The very clear thing that's happening now is that people who are most needing treatment aren't getting it. And the people who least need it are getting too much of it. And you need to figure out where you are in that continuum and make sure that the treatment that you get is tailored to your needs. Second opinions and third opinions are enormously valuable. I think people shouldn't make dramatic changes in their medication or other aspects of their life without consulting a clinician if you're already in treatment. But I think on the other hand, it's important that we not continue this practice of overdiagnosis and overtreatment for people who don't need it, and that we really need to focus our attention on those people who do.
So, as you can see, the criticism is even coming from inside. And I think that he's telling us things are very important. At the beginning, it was only 6 disorders. Now we have 200 disorders. And now he's telling us 1 out of 5 people are taking medicines. And you need to have in mind, guys, that the pharmaceutical industry, they invest a lot of money in their drugs. Then they're gonna do a marketing campaign. That's why we have so many advertisements on the TV. And then they're gonna have even incentives for the doctors to prescribe those medicines. And that way they're gonna get more clients buying the medicines, right? And what he's saying is those who really need the treatments, the medicines, they are not receiving them. And those who don't need it, they are receiving them too much. And we need to be very careful. Another thing that he was saying is, be careful. You don't want to come with a fancy diagnostic with your clients for you to look like, oh, look at me, I'm a very good clinician. Because once that you have bring that diagnosis for the client, that's going to be with the client, and that can impact the clients negatively, okay? And of course, especially if you work in a place where you're going to have to share the medical records and so on, that can be in the medical record for the client forever. All right. Now, how can we assess? We have already talked about this. Remember, on one hand, we want to have a clinical judgment that we're going to try to develop some of it in this class. And number 2, we want to use instruments such as questionnaires, scales, and things like that that are going to help us. There are two concepts that are important when we are talking about assessment. One is the concept of reliability, and the other one is the concept of validity. Reliability is the extent to which an assessment will provide the same result when used by different clinicians. Validity is the extent to which an assessment actually measures what it claims to be measuring. So it is very common that people come and say to you, I was diagnosed with borderline personality disorder. But then I went to visit someone else and he says that no, that what I have is bipolar disorder. Now I'm wondering, what do you think? And you're like, what? Bipolar, and then borderline, and now, and I don't know, I'm not sure that you have neither of those, right? Well, that's not very reliable, right? And the problem is that because we don't have biological markers that can tell us the cause of these disorders, many of the clinicians rely only in their own clinical judgment, but that's very low in reliability. So how can you increase that reliability? Well, using the questionnaires, using the test, that's providing more elements to reliability to your assessment. And the validity has to be with, I am really measuring, assessing what I think that I am assessing. This is a very important concept, especially for the scales or the questionnaires, because some questionnaires, they don't have good validity. They might be measuring something different than what you are trying to measure, okay? Now, you're gonna talk a lot about this in your statistics class. I don't know if I should talk with you about this here, but you just to have in mind that all the tests, they need to pass from statistical studies that can tell us if they are reliable and if they have also validity. There are different types of reliability. Test-retest reliability, which means that even if the person takes the same test in a period of time, in a short period of time, is going to provide very similar results. Because, you know, we learn when we are answering these questionnaires, we learn from them, and then we know how to answer them. And if you take a test and it says that you have, let's think, 20 points of depression, and then you take them again 2 days later and says that you only have 5 points of depression, well, it doesn't have good reliability, okay? Inter-rater reliability, the degree to which two independent clinicians or researchers actually agree when interpreting scoring a particular test. So many of the tests that we are using now, they are very simple to interpret. You have to do a sum and numbers, and then with that you're going to come with a coefficient, and with that it's going to tell you the level of depression or the anxiety that your client is having. But there are other type of tests, for example, projective tests. Psychoanalysts, they really like to use these ones, but they don't have inter-rater reliability, because one clinician says one thing and the other one goes and interpreted something different, right? So you don't want that. Then internal consistency, the extent to which all the items in a test consistently relate to one and another. So you want to know that, okay, all the items, they are talking about depression or they are talking about anxiety. It's not that now they are talking about cancer and then they are talking about diabetes, right? And Cronbach, the A of Cronbach, is a statistical test that is used. Actually, it's the alpha of Cronbach. Okay, it's in the Greek. Is the Greek letter of alpha of Cronbach. And it's a statistical test that is used just to prove that the questionnaires or the scales, they have the internal consistency. All right, so why is that I'm having this weighting scale example? Well, because imagine that you have a weighting scale at home. And one day you go there and it tells you that you have, I don't know about pounds, guys, but I know about kilos. So imagine that one day you go and says like, oh, you have 80 kilos. And you're like, okay. Then you go next day and say like, you have 100 kilos. Wait, what? 20 kilos in one day? Then you go next day and says like, you have 60 kilos. You're gonna go, oh, now I'm 60 kilos. Would you trust in that weighing scale? No, right? Because what you expect is that pretty much the same, that you're gonna have the same results every time that you are using them. Of course, you can be increase or decrease depending on if you are dieting, you are eating too much or not, but those are gonna be not as significant changes, like maybe half of a kilo or something like that, right? Okay, so, and then we have different concepts in validity that I'm gonna skip this because as I say to you, you're gonna talk a lot about this in statistics. And I think that again, it's Saturday, guys, and you want to go and do your things. All right, different methods of assessment. This is important for you to have in mind. First, clinical interviews. These are the most common. This is what you're going to be doing pretty much every day, every time with your clients. You're going to have them in your office, and then having them in your office, you're going to talk with them about their symptoms, about their behavior, about their mood, and you're going to try to come with your clinical judgment. Then we have what it's called structured interviews. These structured interviews are good ways to assess clients, especially at the beginning of our practice when we are trying to develop that clinical judgment, because they come with questions that we're going to ask directly to the client. Then based on the answer of the client, we're going to have other options to follow the conversation on that particular question. So for example, have you experienced difficulties relating with other people? I'm just making this up, okay? Have you experienced difficulties relating with other people since long time ago? And then the client may say like, yes, since I was little. And then it comes with more questions to continue the conversation. Can you explain to me if that was since you were little, if that was since you were adolescent, and so on. Now, the thing here is that these structured interviews, what they are trying to do is to help us to decrease the risk of making mistakes when we are doing the assessment. That's why I'm telling you that it could be a good idea that at the beginning of your practice, you use them. But then little by little, when you feel more confident, you are more familiarized with psychopathology, with the diagnosis and so on, you can just go with the clinical interviews and the psychological test, which is the number 3, right? And I already said to you, psychological tests are very important, especially if they have reliability and validity, right? We are not using psychological tests from magazines like, I don't know, Vogue magazine, right? Answer the following test to know your level of happiness. Well, those we are not using them. We need to use professional psychological tests that they have been tested with the statistical instruments that we have, and that we know that they have both reliability and validity. Okay, I'm thinking that it will be good for you that I can provide you just a brief explanation of the validity concepts, because I'm thinking that it's not okay for me just to jump in the conversation without telling you. Okay, I'm gonna read you the definitions from the book that I'm using, because that is gonna help me to explain this in an easier way, okay? All right, so concurrent validity, where is it? Here. A measure of how highly correlated scores of one test are with scores from other types of assessment that we know also measure that attribute. So imagine that you have one instrument to measure depression, and you have another instrument to measure depression, okay? And you want to, and we know that the number 1 is very good. For example, we know that the Beck's depression inventory, it's a very good, has a lot of reliability, a lot of validity, and maybe you want to use that as a baseline or as a point of comparison with another instrument, okay? another instrument that also says that measure depression. And then you're gonna compare both of them. If the second one is close to the first one, then you can say that has concurrent validity, okay? Face validity, the idea that a particular assessment method may appear to be valid simply because it has questions which intuitively seem relevant to the trait or characteristic being measured. We don't want that, guys. This face validity is what I was telling you about the Vogue scale or the Vogue questionnaire, right? Of anxiety or happiness or whatever. So what we see in those magazines, in those pop magazines, is that they have face validity. What does that mean? They seem logic when you read it. Oh, yes, they are asking me how happy have I felt in the last 3 days. Well, that makes sense because they are asking me for happiness, right? But it doesn't work like that because not because something seems logic, in reality is measuring or assessing or testing what they say that they are testing. We don't want face validity because that it's not a significant way of knowing that that questionnaire is valid, okay? Now, predictive validity is the degree to which an assessment method is able to help the clinician predict future behavior and future symptoms. So imagine that you are using a questionnaire. For example, the Beck depression inventory that I was telling you. It has 2 or 3 questions. I think that they are 2. Yeah, it has 2 questions that it's trying to assess the likelihood of the client committing suicide. That's predictive validity, right? It's going to tell you if the client is likely to commit suicide or not. And you want to know that information because you don't want your client to go there and kill himself, right? So it's telling you how the client is going to do later in the time. And then construct validity, independent evidence showing that a measure of a construct is related to other similar measures. So again, it's when you are trying to understand, like this construct that I'm trying to assess. Imagine that the construct is post-traumatic growth, right? Is it really related to other instruments that are assessing this same construct or not? So this validity is important to have in mind because not all psychological tests have neither reliability, neither validity. You're gonna be like, and how am I gonna know that? Well, if you go to the papers, they're gonna come to you with the statistical information that is gonna help you to see that. Most counselors are not gonna do that. What most counselors do is that they're gonna go with the most authoritative test that have been proved that we can use them, right? Like the link that I shared with you, remember the link from the American Psychiatric Association? Well, the American Psychiatric Association are sharing those to clinicians because they have already tested them and they know that they are valid and reliable. So you can use them, but you can feel comfortable with that, okay? Then biological-based assessment. This is when we are looking for biological markers, and these biological markers can help us to identify if there's something going on with the body. Now that sounds awesome, but remember that I already told you we don't know really the causes of the disorders, and there's no biological markers that can tell us that a person has a specific disorder. Then why are we using this? Because they even provide some information that can be useful for us. So for example, if you do a CT scan to someone and you identify that the person has an abnormality in the brain, well, that can help you to come with not a conclusion, but a correlation to say like, look, this person is having this, and maybe that's why this person is having this mood disorder, right? Or for example, when you are measuring cortisol, we use the measuring of cortisol in research to try to identify the levels of stress or distress that our clients are experiencing. and then we can apply a treatment and measure cortisol again and see if there's an improvement or not. And if there's an improvement, we can say that the treatment worked, see? And finally, clinical observation. This is when we go and we have observation of the behavior in the natural environment of the person, at their house, at their school, at their work. I was really surprised when I conduct a poll with you. I had one of the questions saying like, how did they came to your diagnosis? And I said, do they have clinical observation at home, at school, and so? And some of you say that yes, like 35% of you say that yes. And I was really surprised because it's not as common. Many counselors don't want to do that. Okay, so that's an overview. I'm just gonna mention a couple of specific things now on this, okay? About the structure interviews. There's one that we are still, some counselors are still using. It was very popular in the past, is the DSM-4TR SCID. Now, there's two, one for axis-1 disorders and the other one for axis-2 disorders. Axis-1 disorders are depression, anxiety, and so on. And axis-2 are personality disorder and intellectual disabilities. But that was until the DSM-4 revised, the text revised, okay? Now we don't have those axes. You're gonna be like, well, then why are you telling us this? Well, because the SCID, the SCID2, which is for personality disorder, many clinicians are still using them because the personality disorders, they're still pretty much the same. They remove some and they make a little changes, but you still can use them. And because working with personality disorder clients is challenging, many feel confident using this SCID2, okay? All right, the psychological test, I already shared this with you. The biological based assessment. So as I was telling you, we have many different, some that they are going to help us to measure psychophysiological responses, such as the heart rate, the blood pressure, the body temperature, and so on. And then neuroimaging techniques. We are in a trend nowadays in mental health that they are very enthusiastic with neuropsychology and neuroimagining techniques and so on. And they are hoping that one day we're going to find all the answers in the brain. Well, I'm all about the brain. I love the brain. And I think that it is important for us to understand that there's an significant, I would say even intimate correlation between what happens in our brain and what happens in our mental health, right? Now, but many authors are saying like, hold your horses, guys. Not all answers comes from the brain. Some answers, they just come from social learning. And some others, as the existentialists and the Jungians, they are saying, and not all answers come from the brain and social learning. They also come from meaning and trying to find beauty and true in life, right? And I am one of those guys that I'm like, yes, we need to understand what's going on in the brain, but we don't want reductionism. Reductionism, it's a huge problem in psychology, guys, okay? Theories, they have a tendency to reductionism, try to explain everything from one single variable. For example, right now, we see many theories trying to explain everything from the variable of power. And then they don't want to pay attention to genetics, biology, social learning, meaning, and any of these things. Everything reduces to power. In the past, with the psychoanalysis, everything was reduced, sexual repression and unconscious content. With the behaviorists, everything was reduced to conditioning, either operant conditioning or classical conditioning. With the CBTs, everything reduced to cognition, right? No, we want to understand that to have a complete I don't like the word holistic, but maybe it's the word holistic perspective of our clients and understand that there are many variables shaping our client at the same time. And one of them is the brain. So you want to take a good look on what's happening in the brain. And to do that, we have computerized axial tomographies, positron emission tomographies, magnetic resonance imaging, and functional magnetic resonance imaging. This is like the latest version, and it's pretty cool because you can see in the real time what's going on in the brain, and you can ask the client to do things and you can see it. Of course, you have to do this in a hospital. Like, look, this is the type of instruments that they are using for that, and then they are bringing with pictures of the brain, right? There you have. Look, this is the functional magnetic resonance imaging. So if you want, for any reason, like if you consider that it would be good to know what's going on in the brain of your client, you will have to partner with a physician, right? And they will have to come to this. But yeah, neuropsychologists, they do all this very often. Counselors, not necessarily, guys, but well. And the clinical observations that we already talked, that it's going to the environment, right? Now, how can we do that? Well, here you have some observational coding forms. This is the most frequent, this is the most simple, and honestly, it's the one that I like the most. You have 4 columns. In column number 1, you're going to describe the situation. In column number 2, you're going to describe the behavior that was present. Column number 3, you're going to, well, this is because they are British. They do everything backwards. But generally speaking, we will do it first the antecedents, then the behavior, and then the consequence, okay? I hope that was not like very political incorrect. But you know, they are like that, right? They like to drive in the opposite side of the street, so on. Anyway, so in America and in most countries, we use first antecedents, then behavior, and then consequence. And what are you going to put in antecedents? What happened just before the behavior was present? And what are you going to put in behavior? Well, the behavior that you were observing, and then in consequence, what happened just after the behavior was presented. Because with this, you can come to hypotheses about operant conditioning. You see, remember that operant conditioning is telling us that consequences either reinforce, punish, or extinct behaviors. So you want to identify, what are the consequences of this behavior? Is it being reinforced? But you also want to identify the antecedents. Why? Because sometimes you can just remove the antecedents. And if you remove the antecedents, you have removed the behavior. I'm going to give you an example. People who have binge eating, one of the strategies working with them is to teach them what type of food they should have at home, right? Because the more junk food they have at home, the more binge eating they're gonna be having. So, but before you jump to tell suggestions or strategies, you may want just to observe what's going on. And an antecedent could be like this. The client went to the kitchen and saw the box of cookies, right? The cookies box. And after that, the client ate half of the box. And then what was the consequence? Maybe the consequence was that the client, I don't know, maybe eat the cookies with a relative, and the consequence was that the relative even praised the client for eating the cookies, like, oh, not in the sense of praising them, but in the sense of, oh, look at you, you eat all that. Wow, that's nice. Some people, they feel rewarded for those things. I don't know why. So now you will have to work either in the antecedents or in the consequence. The antecedents, well, if you remove the cookies, there's no cookies to eat, right? There's no behavior that's going to be present. But now we cannot all the time remove the antecedents for our clients. So for example, another, this is gonna make more sense because I'm more familiarized with this. You have a phobia to dogs, and antecedent will be the client saw a dog in the street, the behavior is the client run away, and then the consequence is that the mommy hugged the client for 2 hours saying, poor of you, my little baby. Oh, how are you feeling so stressed for that stupid dog, right? Well, what is the mommy doing? She's reinforcing the anxiety. We will have to work with the mommy and say, hey, mommy, stop doing that. You don't provide affection when your kids are having behaviors that are not healthy for them. Now, I'm not saying that you are not empathic with them. I'm saying that you don't provide affection, because affection is a powerful reinforcement. You will provide the affection if they do the opposite thing. So from now on, we're going to teach the mommy, right? Every time that your kid doesn't run away from the dog, you're going to provide affection to your kid. You're going to tell, I'm so proud of you. Look at you. I know that you can do this. I know that it's not easy, but you are doing it, buddy, and I feel very proud, right? So now what are you doing? You are reinforcing the positive, the healthy behavior instead of the healthy behavior. Okay. Then we have this other one. You have here the behaviors, the target behavior, that's how we call them. And then you just gonna mark the frequency. And this can help you as a baseline, right? For example, if you have a bully in the classroom, well, maybe you're gonna classify what are your target behaviors of this bully, and then you're gonna measure the frequency. And once that you have that, you're gonna try to implement some strategies. And after implementing those strategies, you're gonna have observation again of the bully, and you're gonna see if decrease or increase the behavior. That way you can know if you are being successful or not successful in your treatment, okay? This is pretty much the same, but this is measured based on time, minutes, and seconds, right? It can be good. It can be good, for example, for OCD. It's good for clients with trichotillomania. It could be good as well. Trichotillomania is the people that they take their hair out of the body, and even from down there. And then there's another one that is called trichophagia. They take them out and then they eat it, and they don't realize that they are doing that. And maybe you can observe that. Now, observation can be either you being there present physically or recording the client. Now that we have all this technology, you record it, and then you can come with your antecedent behavior consequence, or you can come with your baseline, whatever you want. I ask to my clients that they have teenagers that they record their kids, or even younger kids, that they record their kids, for example, in the dining room or in the TV room, and that way they can send me the video, and then I can see what's going on there, and then I can come with hypotheses and suggestions, okay? Pretty much the same, you see? All these are pretty much the same. Now, self-observation is when the client is observing their own behaviors, and this is very useful, like with the journaling or the worksheets that we have been talking about it in CBT. But guess what, guys? Now we have these awesome apps, okay? And I strongly suggest you download these apps, get familiarized with them. They are very good, and they are very helpful for assessing behaviors, assessing cognitions, assessing emotions, and they even provide suggestions. And all these are evidence-based apps, okay? They are based on CBT concepts. It's very useful. You're gonna like it. I have been using Uper for a while. Dalio as well is a good option. And there are others, but these ones are the ones that I know that are evidence-based. You don't want to use those that are not evidence-based, okay? And if you get familiarized with these, then you can suggest them to your clients. And then your clients, when they come to you, they can share with you the information, or they even can share them via text to you, and you can know how they are doing. But it's very interesting because they have this intelligence, artificial intelligence and you can have a conversation with that thing, and it's kind of creepy. Have you watched the Black Mirror TV show? Well, something like that. I don't know. Okay, so, and the case formulation, I said to you that we're going to are not going to talk about that because we are already working with that in the CBT class, and then you're going to have a whole semester where you're going to talk about case formulation so you can prepare your case competency, okay? All right, guys, I hope that this was helpful, and I hope also to see you next Tuesday, and enjoy your weekend, enjoy this beautiful day, guys. Have a good one.